Good evening. Thank you for coming for this talk on dementia, the basics. What I need to first do is to cover my disclosures, and these relate to funding that we have received from the funding agencies, the Canadian Institute on Health Research, the National Institute of Health, the Alzheimer's Society of Canada, and other agencies listed there for peer-reviewed funding. I've also worked as a consultant for CME programs, that's continuing medical education for family physicians, as well as clinical trials for the pharmaceutical companies listed, as well as clinical trials fundings over many years for many of the other companies that have conducted clinical research. What we want to cover over the next 40 minutes is exploring the causes of dementia, in particular the underlying causes, Alzheimer's being the most common cause, talking a bit about Lewy body disease and the spectrum of symptoms that you see with these different diseases to be able to help make those diagnoses. We also want to talk a bit about what to expect when visiting a family physician, what might be warranted, and then also to learn about the risk factors for dementia and how we can lower our risks to keep our brains healthy. I'll give an update on research towards the end and also discuss some of the opportunities to participate in research. Alzheimer described the first case of the disease which carries his name over 100 years ago, and this was a 52-year-old woman who developed progressive decline, which began with memory impairment. She developed paranoia, really quickly became immobile, and had died within 4 years. And at autopsy examination of the brain, he described plaques and tangles. And we'll talk a little more about what we understand about these plaques and tangles. And this is what became called Alzheimer's disease, and it was for many years thought to be a pre-senile dementia in those who were under the age of 65. It was also recognized at the same time that people over the age of 65, particularly getting into the 70s, 80s, may die of what was referred to as senility or senile dementia. In the 1960s, when they looked at the brains of people who had this earlier age onset as well as the later onset, it was apparent that these two conditions were the same. They each had plaques and tangles. A further term that evolved through the 90s was dementia probable Alzheimer's disease, and this was really recognizing that we couldn't absolutely be certain of the underlying cause, and that's why we called it probable. But all of these terms are synonymous with each other. Understanding the increase in people who are going to develop dementia is important and to highlight. And this is estimates that come from early 2000s and has been replicated by other studies. Over 500,000 people have dementia in Canada now, and that's just the number of people at one time, and the prevalent number at one time, and then by 2038 there'll be 1,125,000 is the projected number. There is a large number of people each year that develop dementia, and then obviously some who die of dementia, but this is the sort of static number in the population at any one time. Most of these people are living in the community, and it's important to recognize that this is a disease that is more common with old age. So if a person plans on getting old, you need to be careful what you plan for. However, it's not caused by old age, because there are people who in their 80s and 90s who don't have dementia. With these increase in numbers over the next 30 years, we will see a burden which is characterized as both direct costs to the healthcare system as well as the indirect costs to family members, and in particular those directly involved with providing care for people with dementia, the so-called informal caregivers. But this number is actually going to increase dramatically, as shown in this slide, both in the direct costs as well as the indirect costs. And this comes from the Alzheimer's Society of Canada Rising Tide analysis of the costs. The spectrum of cognitive decline characterizes changes that you can see and differences that you can see in people within the population. So there's a group of people, a small number, who we characterize as being supernormal. And these are people who are over the age of 80 who score the same as 20-year-olds on screening cognitive tests. The screening cognitive test that we commonly use is the Montreal Cognitive Assessment, and we'll go over that in a little bit of detail later. People with normal age-consistent loss are people in their 50s, 60s, 70s, 80s who occasionally forget things, occasionally misplace things. They're not concerned about memory loss, and they score 26 or better on the Montreal Cognitive Assessment. There are people who have subjective cognitive decline, and they say that they have had changes in their cognition and thinking and ability to plan over the last few years. And secondly, that they're concerned about it. But they also score the same as the people in the normal age consistent loss on a screening memory test. People with mild cognitive impairment not only notice change, they also have concern, and they score an impaired range on the screening tests, such as the Montreal Cognitive Assessment or MoCA. And then there are people who have dementia, where not only do they have the cognitive impairment, memory impairment, difficulty with planning and what we call executive function, and they have impairment in one or more of the instrumental activities of daily living. So instrumental activities of daily living would include things like cooking, grocery shopping, housekeeping, driving, managing finances, doing laundry. And cooking often is a good example because most people can cook to some degree. Family members are aware to the extent that they can cook. And even if they are not a gourmet chef, people appreciate when there is changes in their ability to perform this activity because it's something that they do regularly. So seeing significant changes, once that occurs in one or more of those instrumental activities of daily living, that's when we call it dementia. So dementia is really a functional state of cognitive impairment. At the bottom, you can see the proportions of people in the population in Canada today who have cognitive impairment. So those over the age of 65 in Canada today, 8% have dementia, 17% have mild cognitive impairment. So 25% of the population 65 and over have at least some form of cognitive impairment, with 75% falling in a normal range. Once you get to 85 and over, 1/3 have dementia, 1/3 have mild cognitive impairment, and 1/3 have normal cognition. So 2/3 of people 85 and over have some form of cognitive impairment. And from mild cognitive impairment, we can progress to dementia, and as we progress, we go through a phase we refer to as a prodromal dementia. These are people that are getting worsening in mild cognitive impairment, worsening on their testing, so the family are reporting that things are declining, their memory is becoming more impaired, they're repeating themselves more often, it's becoming quite apparent that things are getting worse, but they haven't got to that threshold where one or more of the instrumental activities of daily living are impaired. Once that happens, we move into mild dementia, later moderate dementia, severe dementia, and advanced dementia, where a person may be completely mute, may no longer be walking, and at that point may often be in a long-term care facility. And for somewhat arbitrary means, we use the standardized mini-mental state score for the purpose of clinical trials to actually align with those different categories. These are somewhat arbitrary cut points, but that is a sort of a guide that one might use. It's important to remember that none of these scales actually makes the diagnosis of dementia. That determination really is determined by the clinician talking with you, the family members, about the history. And you can see as you progress from left to right, you can see that as a person develops dementia, they have increasing dependence in firstly their instrumental activities of daily living and later their self-care activities of daily living. So that would be bladder and bowel control, bathing, dressing, walking, eating. And at the same time, there may be increasing behavioral changes. So a person may develop restlessness and agitation and depressive symptoms, what we call the behavioral and psychological symptoms of dementia. This shows the progression of Alzheimer's disease. Across the bottom, on the x-axis, you have the years, going out 9 years. Nowadays, I believe that this curve is actually longer than that, quite a bit longer than that, and I think there's many factors that actually contribute to that. All of the supports that we have in the community are important in actually extending that. So things like the Alzheimer's Society, the McCormick Home Dementia Services, the respite programs, the education programs. These are things that actually help caregivers, and these are things that really help extend that across the baseline. And certainly in the last 30 plus years that I've been involved with the business, that's something that I've seen that has been a huge boost to caregivers and family members dealing with people with dementia. But you can see that this curve is fairly got a fairly shallow slope at the beginning, out where we called, where we've put mild cognitive impairment out in this area here, and then it gradually declines. And often it's at this point where family members say, look, it's been declining over the last 2 or 3 years, but it's really got much worse over the last 6 months. And that's when they come to the doctor, when they're really taking the symptoms seriously, and they say, we really need to get a diagnosis now because this is starting to affect a person's functional independence, and later on you may see behavioral problems, and sometimes people may require nursing home admission. Now, there are risk factors for dementia, some of them that we can't change. We've talked about age. It is the most important risk factor, so if you plan on getting old, be careful what you wish for. And then there is the genetic risk, which is the ApoE4 risk, which is a gene. The ApoE, lipoprotein ApoE, comes in 3 different alleles, E2, E3, E4. And if you have 1 or 2 copies of E4, that is a much increased risk of developing Alzheimer's disease. And Tommy Lee, one of our who's waving his hand right at the back there, is one of our study coordinators who's involved with a study that looks at this in people who have normal cognition, who are between the age of 65 and 75, who may have 1 or 2 copies of ApoE. So even for people who don't have any memory problems but have a family history and may be concerned, and it may be because of this ApoE gene, if they've got 1 or 2 copies, as opposed to E2 or E3, if they've got 1 or 2 copies of E4, then they have a much higher risk. And this ties into this family history. So people developing dementia in their 60s or 70s would be concerning. Is there a possibility that ApoE4 is a factor playing in this? Down syndrome is also an additional risk, and these people have an additional copy of the ApoE. They have an additional arm or additional gene, the chromosome 21, and they have an extra chromosome, and they have on that chromosome, they have an extra copy of the amyloid precursor protein. Amyloid protein is the protein that's in the plaques, and they have 3 copies of this amyloid precursor protein, and so they make more amyloid in their brain. So at a very young age, 40s, 50s, or 60s, they start to develop Alzheimer's disease. Now, we want to focus on the things that can actually prevent or change the course, whether it prevents or whether it slows progression. These are some of the things that one needs to address. So we're going to talk about some of these things. One that we can even add here, it would also be obstructive sleep apnea. So people who are having trouble with sleep. These risk factors have come out of some of the longitudinal studies, but I think we're going to see that obstructive sleep apnea is going to be an important risk factor to pay attention to as well. And if we think about risk factors, it's important to think about, well, if I've got one, what if I have two, if I have three? So if a person is at age 60 and they have their risk of developing dementia at that point is about 1%. And you can see there's a doubling every 5 years. And so this is the effect just of age alone. If you add another risk factor, the doubling goes this way. So if you have another risk factor or another two risk factors, instead of being 1%, it's now 4%. And so you can see by age 80, your risk of developing dementia is much higher. So what we want to do is to try and reduce those risk factors, particularly the ones that you can change. You can't change your genes, but you can change inactivity. So just to go back over the formal diagnoses, because I had quickly gone through that spectrum of cognitive decline, the importance of looking at the formal diagnosis is that the information to make the diagnosis comes from you. It comes from the observations of caregivers, and it's the astute observations of caregivers. So if there's something that you get out of tonight, what I want you to think about is your family members or your relatives and the observations you make about their behaviors. So observe the behaviors, observe them objectively. Don't try to interpret them as to what necessarily is causing or what they're trying to think. I mean, that might come later. But try and observe the behavior precisely. What is actually the behavior? What is actually occurring? And when you're discussing that with a physician, describe what the behavior is rather than your interpretation of why he did such and such. So the history that the physician is looking for is, are there concerns about changes in thinking, which we refer to as cognition broadly, and this is more than one might expect for the age and level of education. There is a decline in performance, which is evident over time. So this may relate to memory. So when we talk of other cognitive domains, we talk about planning, and the medical term or neuropsychological term that we use for this is executive function. Attention, we also pay attention to language, has their ability to speak and find words become impaired. What is their spatial orientation like? Do they become easily disoriented? The impairment in short-term memory is most commonly seen in people with mild cognitive impairment, where the underlying disease that's causing this mild cognitive impairment is Alzheimer's disease. So Alzheimer's disease can be a disease which is going on before a person ever develops any memory problems. And you'll see how we can actually detect that later on when we talk about PET scans. So here, to finish off the MCI criteria, the preservation of activities of daily living, which I mentioned earlier. Cooking is a very good one because everyone can cook to some degree. Some people can boil an egg, and if they can't do that properly, you'll know. And if you're the recipient of their cooking and there's problems with their cooking, you will know because they're doing it several times a day. So this is something you're going to see more easily. And cooking is actually a good example of a test of executive function because you have to be able to plan cooking. You have to know what you have. First of all, you have to have an idea of what you want to do. What do you have on hand? What do you have to get? How do you have to bring the proportions together? How do you sequence this? So it's very much a test of executive function. There needs to be confirmation by a family member, friend, or caregiver, speaking with the family doctor, and also evidence of changes of the person over time. And so the family doctor can do this by doing a test called the Montreal Cognitive Assessment, which I'll show you soon, and they can see changes in this score over time. Alzheimer's disease, earlier, this is dementia due to Alzheimer's disease. It's typically an insidious, slow progression. sometimes it's very difficult for family members to say exactly when it began. And sometimes when we're asking the history of people, we will say, how were they in 2014? They were fine. What about 2015? They're fine. What about 2016? Well, things weren't quite so good. I couldn't pinpoint it, but certainly by 2017, I knew there was a problem. So there's a gap there. So we look for this history of worsening, and then again with dementia due to mild cognitive impairment, which often has progressed from, they've progressed from mild cognitive impairment to dementia. You'll see this progression in impairment in learning and learning new information and recall of recently learned information, even if it's something that a family member have told them, we're going to be going and doing this event, and then a short time later they'll be asking, what are we going to be doing? They've forgotten what they were going to be doing. Other things that we look for dementia is the word finding, difficulty with recognizing objects, and also this difficulty with judgment and problem solving, and what we talked about earlier, executive dysfunction. And there has to be the absence of other neurologic conditions such as strokes or any psychiatric illness, and we often do that with other investigations, including scans of the brain. Family need, if you're going to a family doctor, to take memory and language lapses seriously. Don't dismiss them. Don't just say it's because of old age. Start to record it. If there is unusual language abnormalities, write it on a calendar so you can see the frequency with which these might change. So if it only occurred once in that month, but the next month it's occurred 4 times, and the next month it's occurred 4 times in that week, you're seeing a progression. You're actually capturing the changes over time. The family doctors, when you report this, should take this seriously. Now, each family doctor has necessarily different training and different maybe interest in different disorders, but this is something that the family doctors that we're training that come through our different clinics should know to take this seriously. They'll want to confirm the history, and often they'll want to do that with you alone. It's hard to talk about your relative when they're there in the room because you don't want to do that. So it's really important that that's done separately. So the family physician might take a history together, but then they will maybe get someone else to help with the memory testing and talk to you alone to get the details of what you're really concerned about and the progression that you're observing. And then measuring it with this Montreal Cognitive Assessment. So this is the Montreal Cognitive Assessment, and I want to show you this because we should be proud of this instrument. This is a Canadian instrument. It was developed by our colleagues in Montreal, and it has been translated into over 40 languages. It's got traction around the world, and it's free. It's available. You can see it on the internet and download it. You can practice it if you want to. We have some people in our clinical trials are practicing on the way to the clinical trial site saying, dear, what date is it today? And so they're starting to they get better at this. But anyway. This is, and they refer to it as the one with the animals on. So it's the only one where the animals are clearly on one page, and you have to give the animals, when I do it, what I do is start with the animals as a warm-up. We do the clock test, which is also the test that people over the age of 80 have to do. So they have to be able to draw a clock face, and we don't tell them how to do it, whether it's a circle. Some people draw squares. I've had some people draw a little mantle clock. But and the younger ones just draw some digital numbers. So I don't know what's going to happen in another 20 years. We're going to have to come up with a new test. But there is one on the back of the hall here, and I'm keeping my eye on that one there. So they draw a clock face, put the numbers on it, and they have to put the hands at 10 past 11 in this version of 8.1. There's 3 different versions, and so we give people different versions each time they do it. They have to do the cube copy, and then they do this Trails B. This is a modified Trails B, where you draw a number from the first number to the first letter to the second number to the second letter in an alternating fashion. And they have to get the idea that you have to alternate between numbers and letters. And there is a longer version that we use, and this sometimes is used by family physicians to determine whether or not someone should be driving, or whether they should be thinking about getting tested of their driving if they're having trouble with the Trails B. Now, it's not validated for that, but it's certainly used in that way in some circumstances. We can see progression. It's another way of capturing progression of cognitive impairment. Now, this is the critical piece here, so I'm going to want you to say it together with me so that you all get it. So I'm going to say the words first, and then you'll say them back to me. We do this twice. So, face, velvet, church, daisy, red. Okay, so that's how we register those words, and so then we ask the people to remember those 5 words, and then what we do is we go on and do these other tests, numbers forwards and numbers backwards, a test of tapping, the letter A. We get them to do serial 7s from 100, so the numbers are there. And it's scored. We have a couple of sentences. And these, you can see, are labeled on the left side. These are different domains of neuropsychological domains that we are just screening. This is not a full neuropsychological test. A full neuropsychological test would take maybe 3 hours. But this is giving a taste of the different types of tests and domains that we're looking at. So we're looking at language there with repetition of the sentences. There's some abstractions there, the similarities between a banana and an orange is fruit, and then you want to get the similarities between a train and a bicycle. And then we come down and we ask the orientation, get the date and the day and the month, place, where they are, and the city. And then we come back to the 5 words, and then we say to them, now can you tell me what were the 5 words? I heard one other one, banana? No. Okay, thank you. That was good. Okay, so you obviously passed. So this is what we do with really, and that's the most sensitive part of the test. And so a person who has mild cognitive impairment and maybe later moving on to dementia or any of the dementias will start to have problems with the recall of these words without cueing. We can give them category cues, which would be a part of the body, a fabric, or color, a building. We can give them the different categories, or we have to go down sometimes to multiple choice cues. And so we can capture these changes over time. So over time, a person may get worse at these things if it progresses. So this is a way of capturing change. One thing to be very, very careful about with a Montreal Cognitive Assessment, a single Montreal Cognitive Assessment doesn't mean a person has dementia. So if a person goes in the first time and does the test, they may only score 24 out of 30. And it doesn't necessarily mean they have mild cognitive impairment because they've never seen the test before. And when they go again on another occasion, they say, they're going to ask me these words to remember, and they'll have a strategy for remembering. So one has to be cautious. Where it's valuable is looking at it over time, so seeing how it changes over time, and looking particularly at the elements over the time. So one item here is what we call verbal fluency. So here we may ask, say as many words as you can beginning with the letter F in a minute, and you write them all down and you look to see whether or not a person's repeating those things. Now, a person who's got a higher level of education can come up with quite a long list. Sometimes we've had people say more than 20 words, which is hard to write them all down, but we're also looking for repetitions. As the dementia progresses, they may have more and more difficulty doing that. If someone, on the other hand, is not presenting with memory problems, but their problem is really one of language, they may have a lot of difficulty with that part of the test. So initially, they may only be able to come up with a very small number of words beginning with F, but their memory on this portion of the test may be quite good. So that may say they may have one of the frontotemporal dementias, which I'll speak about a bit later. So there are some blood tests we do, and this is just to try and rule out reversible causes of memory impairment. Virtually, these nearly always normal, but we do it just to make sure that there isn't something obviously reversible. We do a brain scan, and this can either be a magnetic resonant imaging scan or an MRI. That's what an MRI stands for. And this is using magnetic energy to look at the brain, or we may use a computerized axial tomography, a CAT scan, and this involves X-rays. So there are two different types of scans, and these are the sort of compelling reasons come up or derived by a consensus panel as to why a person might have to have a scan. Most of the people that we see in our clinic will have had some sort of scan, either a CAT scan or an MRI. If a person is very claustrophobic, or if they've got metal in their eye, or they've got a pacemaker, they probably won't have an MRI scan. But we often prefer an MRI if that's possible, because it gives us some additional information over the CT scan. But certainly a CT scan will rule out a brain tumor, it will rule out major strokes. Now, we wanted to talk about some of the other types of dementia. So we've talked about mild cognitive impairment, we've talked about Alzheimer's disease. This is vascular mild cognitive impairment or dementia. So these people have dementia, they have one or more of the instrumental activities of daily living. So they meet that functional state of impairment. And it's affecting their social or occupational functioning. It's a decline from prior level. And they either, on neurologic examination, have focal neurologic signs. They have signs when they are examined by a doctor to show that there's a difference between one side and another, either some weakness or some increased reflexes. And then this may correlate with a stroke on the scan. And again, they can't have the memory impairment due to a psychiatric illness or due to a condition such as delirium, which is a reversible memory impairment that you see often in acute care hospital after surgery in older people. Older people develop a delirium. So this is what a stroke might look like, and this particular image of the MRI, so this is the scalp and the skull in the MRI here. We're seeing the grey matter out here. This is at the level of showing the cerebral hemispheres here. The frontal lobe is this area here, the parietal lobe back here, the occipital lobe back here. And this is the ventricular system in the central part of the brain where we make cerebrospinal fluid. Cerebrospinal fluid runs out through the ventricular system, out the back of the brain, all the way back down to the bottom of the tailbone. When we do a cerebrospinal fluid tap, that's where we get that fluid from, below where the spinal cord, and then it comes back up over the top outside the brain and is reabsorbed. This scan is showing some strokes, so the arrows are showing some strokes, some small ones. These are probably silent strokes. So when people say, I've had strokes, and they look at you incredulously, they've had no symptoms, these are silent strokes, and these will be in people who have had risk factors for stroke. This is a larger stroke, and this is in the parietal and occipital lobe here. And what you can see here is white matter change here. This is some scouring, but there's also white matter change here around these other strokes, and there's also some white matter change around the ends of the ventricles. So this is the white matter of the brain is where the wiring, we like to think of it as the wiring in the brain. The mental activity is occurring out here, but the wiring is through here, and these are changes, abnormal changes. Now, as a person gets older, there will be some white matter changes, but this is more than one might expect, and you can see that the white matter here is associated with some of these small strokes and a larger stroke here. So this is vascular dementia, not Alzheimer's disease. So getting to the family doctor, they would look at, have ordered a scan, and they would identify some of the reversible factors. And this could be a specialist as well, and the specialist that you might be seeing are some of the specialists listed at the bottom there. And so we want to look at the reversible things, obesity, high blood pressure, diabetes, cholesterol, smoking, atrial fibrillation. These are all vascular risk factors, and I would add to that obstructive sleep apnea. And then encourage reduction and even cessation of alcohol and any medications or drugs that could affect thinking. And then if a person is depressed, using non-drug as well as drug approaches to try and address depression. There's lots of different approaches that can be taken there. Other things that they may want to discuss is the progression, the risk of progression, and they may want to anticipate the potential of progression from, say, mild cognitive impairment through to dementia, and how this might affect driving. Wills and power of attorney, a person's resuscitation preferences, do they want to be resuscitated or allow natural death? And then they may also discuss some of their lifestyle activities, mental stimulation, physical activity. They may prescribe physical activity, talk to you what you would actually like to do or the family member like to do, and do some diet counseling. Frontotemporal dementia, we wanted to mention briefly. There are 7 different variants, and you'll be relieved I'm not going to speak to all of those. We'll only cover 3, which is the behavioral variant, which is the most common variant. Some people know it by Pick's disease, and this is manifest often with changes in personality, inappropriate behaviors, disinhibited behaviors. Apathy is another way in which may present as well. And this often is in people presenting at a younger age, in the 50s to 70 age range, whereas Alzheimer's disease often, commonly, is sort of a little bit later than that, 60s through to 80s, as it's presenting time frame. The second type of frontotemporal degeneration is one which presents with language impairment. So this is different from memory. So a person may be having trouble with their speech. It may be effortful, hesitant speech. They may have some word finding difficulties. They can't find the word, and they'll say, you know that thing that does such and such. They can't remember the noun. And I see some of you nodding your heads and you're relating to this. And so this is certainly common in frontotemporal dementia, but it also is common in other dementias as well. So when the very first symptoms is language problems, then you start to think, is it a frontotemporal dementia, or has a stroke occurred involving the speech area? So that would be another sudden onset of language problems. But as the Alzheimer's disease progresses into its moderate and severe phases, people will also lose the ability with speech. It doesn't mean they're getting frontotemporal dementia at that point. The other type of language difficulty, the early sign, are people who have fluent speech. So they can speak quite fluently. They will also have word-finding difficulties, but the speech is quite empty. And this is the semantic variant. So these are the 3 types of frontotemporal dementia, the more common ones: the behavioral variant, the progressive non-fluent variant, and then the semantic variant. These are medical terms that are used for describing them. Lewy body dementia is another form of dementia. And it presents very early on, if it's just pure Lewy body disease, is with visual hallucinations. So they'll be seeing things that other people can't see. They'll point to someone, who is that person there? Why are they here? Should you be giving them some food? And you're looking and you can't see anyone. This is a visual hallucination. It's occurring in the daylight. Often it's people. It's not threatening usually. They may also eventually develop some Parkinsonism, and they may also later develop fluctuations in levels of consciousness. So they will be quite awake and then suddenly very somnolent, and then very awake or somnolent. It looks almost like the fluctuations that sometimes people get with delirium. We think of it in a similar way. If you've ever seen anyone with delirium who's very awake and alert, and suddenly they're very somnolent and not even responding. It's that fluctuations in levels of consciousness. They may have sensitivity to some of the atypical or typical or atypical antipsychotic drugs. And you ask yourself, why would they be having these? And so they may be prescribed those by a family doctor or sometimes a specialist because of these visual hallucinations, to try and extinguish the hallucinations. And what they do is they become very Parkinsonian. Suddenly the light bulb goes on. This is really Lewy body disease. And those people need to be on a different drug, one of the cholinesterase inhibitors, which we'll come to, which are the drugs that we use for Alzheimer's disease. So the ones used for Alzheimer's disease actually are most effective in this condition, Lewy body disease. And to complicate matters, Lewy body disease may overlie a person who already has Alzheimer's disease. So they may present with typical memory impairment, progressive Alzheimer's disease, and then they develop this Lewy body disease. And it's a different protein abnormality. This is another misfolded protein. in addition to the amyloid protein with Alzheimer's disease. This is an alpha-synuclein protein abnormality. And we don't have any neuroimaging tests yet to be able to diagnose this. Now, if things aren't complicated, you're going to get even more complicated because there is an interaction between vascular disease and Alzheimer's disease. And once people get up into their 80s, they often have vascular risk factors, so they can have Alzheimer's disease, and they can also have vascular changes as well. So you can get this interaction where you actually have people with a mixed dementia. They could have some Alzheimer's disease, some strokes, they could even have some Lewy body diseases there. That makes it very complicated to diagnose. And again, it comes back to the history that you provide in terms of the sequencing of these things. So your observations, you're a partner, you're helping with that diagnostic process. We want to prevent strokes, and these are the things that you need to do. Monitoring of blood pressure. We like people to monitor the blood pressure at home, share it with their family doctors so that they know the blood pressure is not too high, but also you want to make sure it's not too low, because as a person has dementia and it progresses, they may stop eating, they may lose weight, and suddenly those antihypertensive medications were at the right level now are causing low blood pressure. And so some people with dementia end up falling because they stand up and their blood pressure goes too low because they're on too much antihypertensive medication for their blood pressure. And so these things need to be monitored, and this is where you as families can help with that information. Also the diabetes home monitoring, diet, exercise, drugs to lower the cholesterol, stop smoking, and atrial fibrillation, that irregular heartbeat, which causes clots that go to the brain. We have anticoagulation medications, and in some people a coated aspirin may be indicated. There are 6 non-drug strategies to reduce the risk of cognitive decline. So these are the ones you need to memorize. We memorized the 5 words before. Now there's 6 strategies to try and help you. So think carefully about this. Exercise, aerobic or resistive weight exercises, probably the best evidence. Adherence to a Mediterranean-style diet. Mental stimulation. This is not doing the same old, but doing new, different ways to stimulate the brain. And I know through the Alzheimer Society and at McCormick Home, for the people participating in that program, they have things to actually stimulate the brain to keep them active, and this is a way of trying to slow that progression. Restorative sleep, at least 7 hours, reduction in alcohol, psychoactive drugs, particularly ones which may have an anticholinergic action. So a typical one that is over the counter that some people take to help them sleep is Gravol. Gravol is a nasty drug for sleep. It helps you with vomiting now and again, but you shouldn't be taking it for sleep because it has a strongly anticholinergic effect, and we know that drugs that have an anticholinergic effect are a risk for dementia. So we know that, so some people have been on amitriptyline for many years. It's an old tricyclic antidepressant, and these are drugs that people should be weaned off, and they should be removed. Recreational drugs, I anticipate that we will have more known about the effect of marijuana and the various derivatives from that. There's obviously other recreational drugs too that can also affect cognition. Exercise, this is really just to illustrate that there is a lot of evidence for exercise. So Erickson has done a review of what is the effect of exercise, looking at brain MRI images of people before and after they have exercised for a period of time, and shown that people who do the exercise, there's more grey matter. Having more grey matter matters. And having more in the prefrontal cortex and in the hippocampus really matters. Physical activity is important too. So even people who have dementia, there's a number of randomized controlled trials showing that people who participate in activity and physical activity have better outcomes than people who don't. And these are people where they have been randomized to either be on the activity exercise group or a passive stretching group, and showing that with aerobic exercise and resistive weight exercises, they do better. You probably have heard of Mike Evans, who is our Canadian expert to Stanford University, and I think it was Stanford, maybe he went to Berkeley. He went to the San Francisco area, but he was the one who has the whiteboards, and if you just Google 23 hours, you get a very nice whiteboard sequence. It's 23 and a half hours, and the point he's making here is that it doesn't matter what you do for 23 and a half hours, including sleep, but somewhere in the day you need to get that half hour in of exercise, and he gives you all the reasons for it. It's a very entertaining whiteboard sequence. It's about 9 minutes. There are longitudinal prospective studies of physical activity and prevention of Alzheimer's disease. So these are people that are fairly normal, now trying to prevent Alzheimer's disease, with a large number of participants showing that they have a reduced risk of developing Alzheimer's disease. Diet is important. The Mediterranean-style diet, you've seen we've removed the bottle of red wine. It was never an excuse to drink more wine, but it was and actually the Canadian food guide which came out looks very much like this, which is really nice. They've just called it the Canadian food guide, but it is close. It's quite close to this Mediterranean-style diet. So you can see this, and certainly the fish, and not the fish oil capsules, but the fish themselves, and cutting back on sweets and red meats. And there are studies on the Mediterranean-style diet showing that higher adherence to a Mediterranean diet will slow the rate of decline and minimize the progression from mild cognitive impairment to dementia. And this is a study which looks at the combination of these two things. So now we're starting to put some of these things together. So diet plus exercise, does that help? And this is a study done over 12 years. It's a cohort study. It's very difficult to do a randomized controlled trial of a Mediterranean-style diet and exercise. So you say, you people, we want you to sit on the couch there and eat like crazy, and the rest of you can exercise. Doesn't work. No one's going to adhere to that. So we have to do what we call observational studies of groups of people, and then we divide them into different groups. So the group who have low physical activity and low diet score on a Mediterranean-style diet versus the high physical activity and high diet score, and follow those people over a period of time. You can see that their trajectories over time. So at this point here, about 70%, we've got 30% here have progressed to dementia, whereas this group here may be 7 or 8% have progressed to dementia over that period of time. So a big difference. Multi-domain is something, so we're now saying, let's put a lot of these things together. And this is probably the most impressive study done in Finland, so-called the finger study. And this was done by Mia Kivipelto and her colleagues. They took people who were aged 60 to 77 who were at risk of cognitive impairment. So they had some of those risk factors that we talked about earlier. They had 4 different interventions, and they gave different groups the different interventions and combined them. They had 2 groups. The health advice for the control group, they got a lot of health advice, but the intervention group had nutrition, physical activity, cognitive training, and vascular monitoring, very close monitoring of their vascular risk factors. And they found that they got improved cognition and reduced risk of cognitive decline for the intervention group compared to the control group. This was a large randomized controlled trial. Very important study. And from this, in Canada, we now have a proposal. In fact, everyone's wanting to have their finger study. There's worldwide finger now, and in Canada we have the CAN thumb, which is going to be coming to you and people that want to participate in that. This is going to be hopefully a study that will be getting going as part of the Canadian collaboration on neurodegeneration and aging. So there is emerging evidence. I've alluded to mental stimulation, socialization, restorative sleep, alcohol, vitamin B12, and hearing. So addressing hearing is there's emerging evidence that we should be looking at that early on to reduce the risk of dementia and social isolation that comes with hearing. So I think if you think about this, you can see that there's many different things, and it seems to be that there has to be an overlap of many of these things. Increased brain reserve is important, and this may be preserving hearing education, so having a good level of education, and most people in Canada now get that. Cognitive training may be important. And then we have reduced inflammation, so non-steroidal or anti-inflammatory drugs may be important. And reducing brain damage, looking at the vascular and neurotoxic and oxidative stress, treating diabetes, high blood pressure, cholesterol, stopping smoking. And in the center of this is exercise, adherence to Mediterranean-style diet, having a rich social network. So bringing all of these factors together, we're going to have to think of this as not a single intervention, but doing as many of these things as we possibly can. Now, I did allude to the fact that there are some drug therapies. We were part of these clinical trials in the early or in the late last century and early this century when we had these drugs were approved. They have a modest effect if they work in about 35% of people. Some people may get a bit of a boost from these drugs. And you'll recognize their name. Donepezil, rivastigmine, galantamine are the generic names of the drug. They're all generic drugs now. These were the original names from the drug companies that made them. And so these are things to be considered. They certainly should be considered in someone who has Lewy body disease. But they do have a modest effect at best. They can cause nausea, vomiting, and diarrhea in a small proportion of people. And then there's another drug called memantine or Abixa, and it also has a modest effect. It can be combined with those four, any one of those four above. Just to talk lastly about what are the causes of Alzheimer's disease, I talked about the plaques and tangles. So this is what Alzheimer saw. He saw these plaques and he saw these tangles within these neurons causing these neurons to no longer function. And this was different from what the normal state was over here. And there is a theory of the amyloid hypothesis, which suggests that over time, a person who is cognitively normal and is at risk of developing Alzheimer's disease will be gradually accumulating amyloid in their brain over time, and it will start to plateau out. And sometime later, 10, 15 years later, they will start to develop tau tangles due to the tau protein. It's another misfolded protein causing the tangles within the brain and destroying the neurons. And as those neurons are destroyed, you can see that there are changes in brain structure changing, and also there are changes in memory occurring. So memory is starting to appear here. People, family members are starting to recognize it, but what has been happening on all the time are these changes in these two protein abnormalities in the brain. And then later function is changing, and this is where a person's developing diagnosis. You can see a lot of stuff has been going on before you even get to the diagnosis of dementia. A lot of biochemical changes have been occurring in the brain. Now, we can image this now. So this is what a PET scan would look like using an amyloid tracer, a tracer which is injected into a vein. You then go into the scanner. This is a scan with very little amyloid in the brain, a so-called negative scan, and this is a scan that is considered a positive scan. Now, these are scans that aren't clinically available. They're expensive, $5,000 each, and they are part of research studies. So we want to be able to make sure that people that go into studies to remove amyloid from the brain, that they actually have amyloid in the brain. And this is from one of the most recent studies removing amyloid from the brain, and this is the dose effect. So these are the people on placebo. This is at baseline and at 1 year. Not a lot of difference, maybe more amyloid in the brain. And this is the dose at 3 milligrams. You can see there's some removal of amyloid at 6 milligrams, and at 10 milligrams per kilogram, you can see even more removal of the amyloid. And so this is phase 1 data, very compelling data, and very encouraging for some of the studies that are going on. We're participating in some of these studies, so you'll hear more about those. We also can now image tau, and so this is 4 different people, 3 normal controls, and a person with dementia. And you can see the amyloid accumulating here, and these, as you go across there, they've got more amyloid in the brain. But this is another person who also has not only amyloid, but this is the tau image here. So the tau accumulating in the part of the brain involved with memory and then spreading throughout the brain. There are reasons why you might want to participate in studies. There is the placebo effect, which is the positive effect by being in a study. You think you may be on the study medication, and it gives a positive boost, even though you may be on the placebo. You have close medical monitoring. A person may receive stimulation just by being engaged by our research coordinators. They see them every month, and you develop a relationship with those people. They become your friends. They can help get you to resources in the community if you need those. And then you can then have continued access to the drug during the open label phase of the study. So following the blinded phase, there is an open label phase where you can get the medication while it's continuing to be evaluated. And so a lot of people relate to this, altruism. I may be benefiting from someone else's altruism, from the medications that I'm on. I want to give back. I can give back to this condition. I may not benefit, but one of my family members might. We're doing an observational study. This is a really important study. We're leading this in Canada with 30 sites that we're training. Our coordinator, Sarah Best, is the lead here, and she is helping, and Lauren Cole is also helping with evaluating people for this important COMPASS END study. We're trying to recruit 1,600 people from all of these different conditions, 650 normal controls. There are various biomarkers that we're doing in this particular study. There are some studies. I mentioned the study that Tommy Lee is involved with, the Nevada study, looking at the genetic risk of Alzheimer's disease. So people who are have that ApoE4 gene, 1 or 2 copies, can go on a medication for 3 years to try and reduce their risk as part of a randomized controlled trial. We also have trials to remove amyloid from the brain, and this is a subcutaneous injection given once every 4 weeks and then every 2 weeks over 2 years. And Sarah's contact is there, so if you are interested in that sort of thing, please get in touch with her. So in summary, you are most important in being able to help us come up with the diagnosis on your observations and also the progression. Changes in memory, language, mood or behavior. Repeated tests over time will actually provide objective evidence, and this can be done by the family doctor and the specialists. We work really closely with the specialists, with the family doctors. Some of the family doctors are in the primary care memory clinics, or they may be in family health teams, or they may be in their own clinic, and they fax us the tests. It's a one page, we can see it, and then we can look and see how it changes over time. Try the non-drug approaches, and then I encourage you to encourage your family members and yourselves. If you're a normal older person over the age of 60, Lauren would be happy to talk to you about being part of she's standing up at the back there, waving her hand. She'd be happy to talk to you about the COMPASS ND study if you want to contribute to that. Okay, so I just need to acknowledge all of my colleagues, Jenny Wells and I in Geriatric Meds, and Elizabeth Finger and Stephen Pasternak in Cognitive Neurology at Parkwood Hospital, and all of our various coordinators. Some of them you may have mentioned, recognize their names there, our research assistants, and our nurse clinicians. Jennifer Fogarty is our neuropsychologist who helps us. She's now very busy. She's got a waiting list of about 9 months assessing people that we refer to her. Our waiting list for people to be seen in the specialist clinic is about a year. Our follow-up now, the earliest appointments we have is 3 years. So this is a big problem. We need to work very closely with the family physicians. We need to work very closely with the Alzheimer's Society, with the McCormick Home, to try and keep people as well as they can be in the community. Thanks very much.